Thank you very much, Charles, and thank you to the organisers for inviting me to speak. I will make you really sorry that you did. Kerin, this is a really nice title. It does allow me to talk just about anything, which is kind of what I do anyway. So, now, in terms of the strategy for cancer control in Ireland, this document was produced in 2006 from the National Cancer Forum, and it had a fairly far-reaching and a fairly expansive set of objectives, which involved reducing the incidence, morbidity and mortality from cancer by 2015, to increase awareness and education and develop state-of-the-art cancer centres incorporating education and research. And as we always do in Ireland, we thought 4 of those should be in Dublin and there should be 4 others for the rest of the country. One of which was here, and we have a special arrangement with Letterkenny because of the geography in the west of Ireland. Now, these cancer centres were based on the fact that there was going to be a general medical and surgical infrastructure, availability of critical surgical subspecialties, medical oncology, multidisciplinary environment, and then academic environment, particularly for cancer research. And these were announced at the time as going to be constituents or centres of excellence. So, and I suppose the constituents of excellence, as envisaged, would involve easy access for patients, high volume cases leading to good outcomes, provision of a multidisciplinary team with appropriate availability of diagnostic and therapeutic devices, and particularly the availability of individualised treatment strategies. As we know, cancer incidence in this country has increased and is projected to increase dramatically indeed over the next 20 years. With regard to breast cancer, there's about 2,500 cases per year in the south and about 4,000 cases altogether on the island, and 3,500 I think actually to be precise. And this is a 50% increase from the mid-1990s, and there's a projection that the incidence of cancer will double by 2040. So it is a huge healthcare problem. Now, with the delivery of care, we've seen people touch on the availability of screening. And breast cancer screening brings this to mind. The Wilson and Younger criteria, as shown here, should be well known to all economists, right? These are the criteria that must be met before screening is possible or appropriate. And they're from the World Health Organization, 1968, and they include that the condition is an important health problem, natural history is understood, detectable early stage, treatment at that early stage is beneficial, there is a suitable test and that test is appropriate for mass use, and there must be a substantial risk of benefit. There must be adequate healthcare provision in order to provide it. The benefits outweigh the risks and the costs are worthwhile in relation to the benefits gained. And this is the one thing that's always quite surprising from my point of view in terms of people say, oh, we'll screen for this, that and the next thing. Screening is costly, and a large proportion of people who are screened actually may be impacted negatively by the screening process. So in the context of knowing whether screening is good or bad, these criteria must be met. And internationally at the moment, cervical cancer, breast cancer are probably the only 2 criteria that meet it. And the one big thing about breast cancer is that if the disease is picked up early, it's usually cured, but also the treatment inflicted on people is usually much less. And that doesn't apply for lots of cancers. But anyway, there was a big stimulus for screening, and this Margaret Thatcher, 1988, introduced it in the UK, and as we know, we always follow what the UK does. One of the major advantages of setting up screening for breast cancer was that it introduced the concept of the multidisciplinary environment, where clinicians, radiologists, pathologists and surgeons got together for diagnosis, and then there was a treatment team that involved medical oncology, radiation oncology and surgery. And in advance, people discussed what went on, so that you made an appropriate decision based on the information available, and that everybody involved in the care pathway was involved up front, unlike what happens in some other cancers where some people may be late arrivals to the table and decisions, sometimes inappropriately, might have been made. Now, of course, this is a costly business, and the cost of treatment, as I'm going to show you in a minute, have escalated dramatically over the course of the last 20 years. So much so that our National Director for Cancer, Susan O'Reilly, announced a national plan for medical oncology in 2011 because a lot of the costs are related to the drug treatments associated with cancer. And these, she said, would involve multidisciplinary human resource planning, evidence-based national guidelines, baseline assessment of drug safety processes, quality and safety policies for safe drug delivery, and perhaps most controversially, a National Cancer Control Programme Technology Review Committee for oncology drugs and related molecular tests. And this would involve giving a budget to some people who would decide on how that budget would be spent. And we heard rather elegantly from our European professor from Stockholm this morning, in the context of the local county's delivery of cancer care, how at times there can be a treatment plan that involves 100,000 for a drug treatment or the pay of a medical oncologist. And I think that sort of approach actually would lead to some very critical decision making. So I just wanted to touch on the changes in breast cancer management that's happened in my lifetime, indeed in the last 15 years, in the context of what's happened with regard to the management for patients out there. And the picture on the right, this was the treatment that was reckoned appropriate for breast cancer 100 years ago. William Stewart Halstead, the father of modern breast surgery and the programs of US surgical oncology, radical mastectomy with the attendant comorbidities, including lymphedema in many cases, and so on. But this cured a large proportion of people giving this fairly devastating treatment. And then that was de rigueur until the mid-1940s. Then during the 40s, we got into a situation where simple mastectomy came into play, and it wasn't until the 70s and 80s that Fisher in the US and Veronesi in Milan and others with the National Surgical Adjuvant Breast and Bowel Project, it was called, were set up these multi-centre trials comparing lumpectomy and axillary clearance with mastectomy. And they found, guess what, the survival was the same in appropriately selected cases. So now it became de rigueur to move towards a conservative surgical approach of lumpectomy. And in the last few years, we've moved to a situation where we don't need to take away all the axillary lymph nodes anymore. We just need to take away the critical one. And if that's not involved, we don't need to do any more. Then adjuvant systemic therapy was introduced. And in the 80s, cyclophosphamide, methotrexate, and 5-FU, the old chemotherapy regime, which costs nothing, had a major impact on the outcome from breast cancer. And then we had tamoxifen, which was appropriate for hormone-sensitive disease, where we give a patient a tablet for 5 years. And it became a sort of a blunderbuss era then, where we thought everybody did better if they all got that treatment. And then over the last few years, with the incidence of molecular classification of tumours, we're able to separate out different tumour types and have identified patients that don't derive any benefit from some of these treatments, as I'll show you in a little more detail now. But just looking in practice in work that we did here and which Kerin O'Neill has helped with, over the course of when I came back in 2004, the treatment situation had changed because of breast programmes being introduced and so on. And we compared the diagnostic techniques with 2005-06 with 10 years earlier. And interestingly, on the left, you'll see that 93% of women in the west of Ireland who were diagnosed with breast cancer in the mid-90s had an open surgical biopsy for diagnosis. This involved going to sleep in an operating room and having an incision made in the breast. We moved into a situation where we were able to do core biopsies, which is just local anaesthetic and a biopsy. So the patient came and went and had their diagnosis made. And then just to illustrate in terms of surgery, you can see on the left in 1995-96 that the vast majority of people had a mastectomy for treatment of their breast cancer. That's quite surprising, because that is not like, it's not today or yesterday, but it's not a long time ago, 16 years. West of Ireland, 186 cases in those years, and the vast majority had mastectomy. And by comparison, you can see that 2/3 of people had lumpectomy in 2005-2006. And then with regard to the management of the axilla, as I can see, in 95-96, everybody had all their axillary lymph nodes taken away, whereas 2/3 just had a sentinel lymph node biopsy, one gland removed in 15 years later, or 10 years later. And then probably most excitingly is that the incidence of breast reconstruction, even when I came back to Ireland in '99, it was unusual for women to have a breast reconstruction if they were having a mastectomy at the time of surgery. But in the practice, you can see here in the differences that have happened in 2005, 2010, that the vast majority of women now, about 75%, 69% of women now who have a mastectomy done will have a breast reconstruction at the same time. But gladly, less than 1 in 3 need a mastectomy as treatment for breast cancer. So what I've shown you is that in the context of, say, the actual management of cancer, from the point of view of the diagnostic techniques, the therapeutic techniques and the surgery, there's been a fantastic, or well, a major change over even a 15-year period in this. We've published that. Now, this is my soapbox slide. Right, it's one that I've made up myself, but I'm not sure where I got the information from it, and it may be absolute bunkum in terms of the health economics community, right? But what it does is it shows this prospective randomized trial that's being carried out on cancer, right? And the treatment is the same for one group as it's always been, the regular treatment, and then a new therapy is given for the second group. And these are the outcomes. And what it shows is that in the context of survival, there's a 20% improvement in outcome, right? And then we talk about the individualization of treatment and how does that impact? Well, if your survival curve, if you have a good prognosis disease, say if it was breast cancer and the patient had a tumour picked up at less than 2 centimetres in size, right? The normal survival curve would be along this line such that at 10 years you'd predict that 90% of the population would be alive. But this new treatment improves things, so it goes to 92% alive, right? Now contrast that with the intermediate group here who have about a 60% 10-year survival. 20% of 40%, which would have been the group that died, are alive. 20% to 40% is probably 8, I think. So we go from 60 to 68 alive in that group, right? And then group C have a worse survival. 80% of them would have been dead. But actually we saved 16 of them. So their survival goes from 20 to 36. Now, I'm sure health economists would say that's vastly different depending on which group you're in. The public may say, sure, it's all the same, they all do better. But I'm telling you, they don't, right? The people that are below the line on each slide haven't gained any benefit. They've all died. Sorry, the people below the line, right, would have been fine without the treatment. This new treatment, whatever it is, in each group. So if we and the people above the line have died. So in this group, 100 patients have got the treatment, and the 2 in the middle have benefited. But the 100 have all got the side effects. So what can we say? The absolute improvement in outcome differs greatly between the groups. The relative improvement is the same for everybody. The clinical utility of the therapy varies with each group, and the interpretation of results varies. Some people will say, should they all benefit? Others will say, don't think so. And then in terms of the cost, there must be a difference in cost depending on which group you're in. Now, I want to apply that in terms of breast cancer. This is chemotherapy in breast cancer, right? One of the early trials. And then the NSABP B20 trial, which was published in the New England Journal of Medicine, the premier journal in 2004, right? These are the survival curves. There was a 4% improvement by adding chemo to tamoxifen in this group with early breast cancer. They were all node negative, hormone sensitive. So you think my first curve didn't mean anything, or this is it, right? So what happened was, we had a 4% improvement in survival. This is years, right, at 12 years. And the interpretation of this around the world was that every patient with early breast cancer, hormone sensitive, should get chemotherapy. Our interpretation has got to be there's something different about the group in between. And there was. And just in the last couple of years, we've got into a situation where we now do molecular profiling. And we have a test called the Oncotype test, which is based on the genetic the genetic, it's a 21 gene signature, 15 genes of which are informative and 6 are control genes. And this gives a recurrence score for each patient between 0 and 100, right? And this is the survival curve overall. But the interesting thing is that depending on what the recurrence score is, we can predict whether chemotherapy will save people or not. And the bottom line is this, I don't know if it projects, this was the application to the NSABP B20 study, which I showed you, right? They took this 4%, and if you took the patients in the study, and these are the whole numbers in the study, which I think I can read here. In the score less than 18, there were 218 who got tamoxifen and chemotherapy and 135 tamoxifen alone. There were 11 events in one and 5 in the other, this group. So the outcome was the exact same in whether they had chemo or not. This group in between we couldn't be sure about because the numbers are too small. And all this, 4%, were in this group who had a recurrence score greater than equal to 21. So this test is fantastic. It identified the small group of women who got a substantial benefit from chemotherapy. And we thought we were onto something really big. And in our own unit, we can see that because of this, the group of people who prior to this would have been getting chemotherapy, now only 14% of the low score group, 2 out of 3 of the intermediate score group, which is much smaller, and then 16. There's only 16 from our follow-up of these 237 patients. This is in our practical application of Oncotype. But from the health economist point of view, I think what makes really interesting reading is Oncotype is not a cheap test. It costs about $3,000 to do, and it's done centrally in one laboratory in the US. And in the context of 2007 and 8, this was the chemotherapy that it was replacing, right? Costing $6,000 per cycle. So if you saved one patient in 2 chemotherapy, you were also saving the health service cost. But guess what? In the last 5 years, this has come off patent. So now the cost of chemotherapy is only 1/12 what it used to be. So this new treatment, which is hugely important for women, are very, very useful in selecting people who benefit from chemotherapy and so on, has now a cost implication with it. I think I promised Charles I wouldn't go on very long. I have like 2 minutes left. So in terms of comprehensive database from our breast cancer unit, we've got one. And we have, that's matched to 3,500 specimens that we've collected over time now, which I think will allow us to, to make improvements in care. And we can answer questions like younger age as a prognostic indicator in breast cancer. Do young women do worse? And this study of 276 women less than 40 from the 2,800 in the database show that they have a slightly different type of disease, but stage for stage they don't do any worse. In terms of bilateral breast cancer, there's an epidemic of surgeons in the US at the moment doing bilateral breast surgery when a young woman presents with a cancer on one side. We've shown from our data that, there was 2.1% of the population in our cancer centre have bilateral breast cancer presentation, and another 2% get breast cancer at a mean follow-up of 6 years in the contralateral breast. So 4% overall. So if you're doing lots of bilateral breast cancer mastectomies, you're over-treating. In terms of the economic impact, this is just the economic. Kerin O'Neill had used a bit of magic in terms of figuring out what the cost was. You can see that the total expenditure on breast cancer between 1995-96 and 2005-2006 changed dramatically, and the cost quadrupled overall, and it was mainly due to adjuvant chemotherapy, which cost 14 times more, bisphosphonates and Herceptin, which we've heard mentioned already. So breast cancer in general, what's different? Politics, probably. Maggie Thatcher introduced breast screening. We have screening, that was a big move at the time. I think, however, in terms of screening and the application to healthcare and cancer in general, we need to be aware that the Wilson and Younger criteria apply. We need to apply them. Big advantage with breast cancer is, I think, as I've shown you, early diagnosis means less surgery and less adjuvant treatment now. We've built a multidisciplinary expertise. Different subtypes respond differently to treatment, and we're aware of that. and by having a significant cancer centre we can improve the research outputs and do practical translational research. And in the context of the infrastructure for delivery of care, breast check and symptomatic breast unit we have here, and translational research facilities, and integration with cancer research programmes like John Fitzpatrick's mentioned, like that we've got going in this economics forum today and so on, I think will lead to significant improved outcomes for people with cancer, and that's all that's important. Thank you.